Ciao mondo, hello world, hola mundo, hello monde, konnichiwa, ni hao, namaste. We're here in Rome at the Consensus Conference on Hemoabsorption Hemodialysis for Chronic Patients with Professor Francisco Maduell from Barcelona. We actually met approximately a year ago in Barcelona where we had a meeting on this subject. But we take special advantage of the presence of Francisco because he is considered the expert of hemodiafiltration. And so, what do you expect from this new therapy, Francisco?
Well, this is an interesting question because when in dialysis treatment we improve with the maximum diffusion and then we add with the maximum convection, with high volume convection, we need something more to improve the removal capacity of the treatment. Then this open a new opportunity to improve the removal of uremic toxin, the absorption. What is the possibilities of these new resins that they can offer the possibility to remove a low molecular or protein bound uremic toxins that in the actuality we have not the opportunity to remove with more than 60-70%. Probably with this new physical, biochemical, additional treatment, we can improve this removal.
So, this is interesting because, in one side, you can figure out this treatment as a possibility to manage complications in those patients where hemodiafiltration is not feasible. In other cases, you can additionally use this treatment together with hemodiafiltration. So there are these two different possibilities, right?
Yes, it's right because you have the possibility to use the HDF. It's okay. You don't have the possibility to give this additional treatment. You have the opportunity to combine your dialysis treatment plus this cartridge and improve the removal of probably these middle molecules and high molecules that don't removal with the conventional hemodialysis.
Yeah, the discriminant can be, for example, the blood flow. If you're not able to reach very high blood flow, that would be required for hemodiafiltration to achieve enough convection, then you can probably use adsorption instead of hemodiafiltration. But if the patient is already doing hemodiafiltration and still have some complication, you can probably test the additional value of adsorption with this, incrementing further the removal of some specific substances, right?
Yes, it's right. It's right because the blood flow is a specific point of view. I suggest always to use the maximal blood flow because it is better for all, for diffusion, for convection, and I don't know if it can help in the absorption. But all that we can add to improve the removal of uremic toxin will be advantage for the patient.
Sure, because at the end, hemodiafiltration is in any case limited by the sieving coefficient of the membrane. So there are some, for example, protein-bound solutes that cannot be removed because of the permeability of the membrane. How do you see the percent of patients to be treated with additional hemoabsorption in the overall population? What could be?
I don't know because this is a new treatment in Europe or especially in Spain. It's very low use. It is a specific, a very low unit. We have to do more research in this aspect to recommend it to use on a specific treatments, a specific removal of special molecules. I don't know exactly what could be this percentage of the patients.
But for sure, the meaning of this conference in Rome is the one to make people aware of the possibility. Your group is dealing with monitoring the efficacy and so on. So I expect in the future to have between 10 and 30% of the population possibly using this technique.
Yeah, it's possible because this is a percentage that there are problems with the pruritus and there are problems with the leg,
Complications.
the leg syndromes. That when you don't achieve adequate treatment of these patients, this 20-30%, you need something more to additional treatment to improve these patients.
Excellent. So thank you very much to Professor Maduell from Barcelona, and thanks for joining today Cappuccino in Rome. Excellent.
Excellent.